Hey, good morning, guys. Steve Dietrich. I have the privilege to be a respiratory therapist for 36 years. I love what we do. And you'll hear me say this multiple times. We're the smartest kids in the building, and people just don't know how smart we are. But we're going to talk about this morning how important it is for expiratory flow bias in secretion clearance. And the focused product line on that is OPEP VPEP devices. So when you look at this, you'll see it, and everybody probably is already doing that therapy. Again, it's nothing new. It's been out for a long time, but again, it's a really great tool that allows us to do alveolar clearance. All right, so here's the objectives. Review normal mechanisms of mucociliary transport, discuss some of the common methods for using expiratory airflow to enhance secretion removal, and then discuss the importance of ensuring expiratory flow bias to enhance secretion clearance in OPEP therapy. Describe three mechanisms which OPEP devices aid in the clearance of secretions. State the effects of increasing resistance on an OPEP device, and then name one simple thing the respiratory care practitioner can do to enhance expiratory flow bias. All right, so if you're ready, I'm ready, and here we go. Now, this is going to be a review of what you learned in school. This is nothing new to us. We all had to go through this in school. It's like, here it is. So when you see these slides, you're like, oh, I remember that. I remember that. So again, mucus is produced by goblet submucosal glands, about 100 cc's a day. Two layers of mucus, soil and gel, soil thin, watery, gel thick. Cilia beat up and down, moving secretion cephalid at about 11 to 13 cycles per second. So again, when we look at that, what would a patient do that would blunt the ciliary beat? What would be something that our typical patient does when you see that? Yeah, if they're smoking, that stops that cilia. So we need to encourage the patient to stop smoking, Mr. and Ms. Smith. That's not a good thing. And again, we see it, we talk about it, we get it. So again, healthy mucociliary escalator moves respiratory secretions toward the oropharyngeal area, where the final clearance is achieved by swallowing. Increased air velocity during exhalation also contributes to mucus movement. As the diameter of the airway decreases during exhalation, velocity increases. So what does that mean? Again, this is stuff that we learned in school. We think about it. Now, let me ask you this. How many of you have flowers or plants or something at your house? So you go to water them. So you have the hose in your hand, turn the water on, the water comes out. Well, I need to get those flowers in the back up by the fence. So what do? You put your thumb over the outlet of the hose, and what does that do? That increases the velocity of that water going so it sprays to the back of the fence. So you do that. The same thing happens when we have the diameter of the airway decrease, the velocity increases. And again, I say this all the time, take a big deep breath in and then cough real big, spit, but don't spit on the therapist. Therapist good. Don't spit on the floor either. I don't want that either. So what's the difference between flow and velocity? Just like what we've talked about. Flow is the volume divided by time. Velocity is flow divided by the cross-sectional area, just like the hose. So when you're at the bedside, you're looking at your patient and you're saying, okay, Mr. and Ms. Smith, here's what I need you to do. You probably do this anyway. You probably visualize in your head what that airway is doing. So again, you're narrowing that so you get a little more velocity. So it's like, okay, I got it. I'm ready to go. So cough and spit, now the therapist. So flow bias. And this is the whole point of our program this morning is flow bias. The preponderance of flow direction is based on expiratory flow rates. Patient breathes in, patient breathes out. Patient breathes in, patient breathes out. A higher peak inspiratory flow than expiratory flow generates flow bias toward the lungs. This is referred to as inspiratory flow bias. And then the opposite on that, a higher peak flow, expiratory peak flow than inspiratory flow generates flow bias toward the mouth, referred to expiratory flow bias. Again, we've learned this. We understand the physics, the dynamics of this. But again, I need to have that patient take that slow, deep breath in and then blast out. That's expiratory flow bias. And that will help move secretions, cephalid, so the patient can cough and remove that out of the lungs. Make sense so far? All right. Expiratory flow bias is important in secretion clearance. In order to move secretion cephalid toward the oral pharynx, the EI ratio needs to be greater than 1.1. And again, this is science that people have known and people have written about. It's well documented. So I'm not telling you anything you don't know or hadn't read about. I'm just reinforcing that to make sure that when you're at the bedside and you're using your OPEP device, that you encourage your patient to take that slow, deep breath in all the way and then hold it so we can get some alveolar recruitment and then blast it out. So again, something we've done for years. All right, the slower the inspiration, the greater expiratory flow bias. Makes sense. We understand that. So considering the following four examples, and notice the longer the inspiratory time, the greater the expiratory flow bias. So again, coach your patient along. Mr. Ms. Smith, slow deep breath in, hold it, and then blast it out. Here we go. And here's the waveforms. And we look at waveforms all the time. We do it on our ventilators. We're nerds about waveforms. So when we built this program, I say, yeah, the waveforms would be good. So here it is. So here's a half-second eye time, and there's 27 liters. Now I want you to look at the bottom side. That's the inspiratory side. Look at how the waveforms are breaking. So it goes up and down. It oscillates. So let's look. Gets a little more. So again, I'm seeing a little more activity in that waveform on the expiratory side. And again, we visualize this, we see this, we place our healing hands on the patient. Again, eye time. See how that waveform breaks up? I mean, it just moves the secretions forward, breaks them up. It's like waves. Here again, just a little bit more time. Now look at that expiratory flow bias, 45 liters a minute. That's huge. That's really big. So again, eye time is important on that. Slow deep breath in and then blast out. When I was a kid, I grew up in Southern California. I grew up in Anaheim. And I started surfing there when I was 12. And my neighborhood friends, Scott and Jamie, we would go, and this is when you could hitchhike down to the beach. We lived about 30 miles from the beach. And I loved going in the morning, watching the waves break. And as that wave would break, the sun would catch that and the spray over the wave. Now you can see that on any wave anywhere, but I thought that was the coolest thing. That wave is breaking up as it goes forward. So this is what we're doing with that mucus. As that wave goes forward, it's breaking that mucus up, so it's easier for the patient to move it out and spit. So all we're doing is we're creating a wave with that expiratory flow bias. So think about that. Here's that mucus coming up. I'm breaking it up into smaller pieces, and then the patient can move that out and spit and clear their airway. Common methods for secretion clearance. Two basic principles for secretion clearance. Move air behind the obstructions and ventilate regions distally. Yeah, we get that. Modulate expiratory airflow to move secretions toward the oral pharynx. This isn't anything that we don't know, that we haven't done for a long time. We understand what this is. So again, take that breath in so it moves air behind the obstructions and ventilate regions distally. So I want you to visualize what that looks like. We're going to look at a slide here in a minute that talks about that, that visually shows that. So when you're looking at your patient and you're coaching them, visualize what this looks like. And then modulate expiratory airflow. That's that valve that breaks that mucus up. And we see this all the time. All right, so here's the techniques. Cough Okay, the patient spontaneously huff coughing. We want them to take that breath in, then active cycle breathing, air in, air out, air in, air out. Autogenic drainage. We do that all the time. It's the way God made us. We move those secretions forward. That's the way we're made. We're put together like that. So again, a cough, normal defense mechanism to clear secretions. The flow can exceed 500 liters a minute. So here the glottis opens up. That's a lot of volume when you think about that, 500 liters a minute. Again, there's a lot of dynamics that goes into that. And again, there it is, dynamic compression of the airways, increased velocity, producing the shear force detaching mucus from the airway wall. Remember the waves? A key to an effective cough is what? Miss Patient, take in a big deep breath, a big deep breath, and we'll be all good. So they take that big breath in. So again, for the waveform nerds like me, this is what it looks like. Here's the anatomy of a cough. Patient takes that breath in, then blows out. Notice the waveforms up at the top. We see that. So here's the volume, I time, glottic closure, E time, expiratory pressures, expiratory flow, the flow bias, 2 liters. Again, we get this, we understand this, but I built this slide for just for the waveform so we get a visual of what that looks like. I mean, again, when you're placing your healing hands on a patient and you're having them take that big deep breath in, you're looking for bilateral chest wall movement and all that stuff. And then you have them cough, it vibrates their hand. This is what it is. I mean, it looks like that. So there's the visual that goes along with the actual. Huff coughing, again, forced expiratory maneuver with an open glottis so that the patient takes that breath in. You've done that. We learned how to do that. As dynamic compression occurs, the airways narrow, velocity increases, propelling secretions cephalid forward. Get them to move that out of the lung, out of the alveolar level. Active cycle breathing. Several minutes of relaxed diaphragmatic breathing, and then 3 to 4 active deep inspirations with passive relaxed exhalation, then back to relaxed diaphragmatic breathing. Then we repeat that. And then the huff coughs, followed by, 2 or 3 or 4 or 10, huff coughs at higher volumes. Again, I'm encouraging my patient. I need you, Mr. Patient, to take these big deep breaths in, slow, and cough and get that stuff out. Nothing that we don't know. Again, for the waveforms, here it is. So active cycle breathing is what's going on. We had to learn this in school. Those of you that do PFTs understand all this. We see this waveforms, mechanical ventilation. Well, here's what it looks like. Just a normal active cycle breathing. And again, the thing that I like about this is where does gas exchange take place? At the FRC. I'm wanting to increase FRC so I have better gas exchange. And that's what we want. That's exactly what we want. So autogenic drainage, start with low volumes from the expiratory reserve. So you're having them taking a larger breath. Repeat 10 to 20 breaths until the secretions are felt gathering in the airways, and you'll hear the patient and they'll cough reflexively. But again, you're trying to suppress that urge to cough because again, I want that mucus to get out. So again, a series of even larger breaths near vital capacity, and then take several huff coughs. Get that stuff up and out. Move it out down the large conducting airway, cough and spit. So again, here it is in waveforms. We get it. And again, think about what's going on dynamically with those secretions in the airway. It's unsticking, it's collecting, it's evacuating. We talk about secretion clearance, we talk about this, but again, this is what it looks like dynamically through a waveform. So it's unsticking. I'm getting it off the wall. I'm collecting it and then I'm evacuating it. So I'm coaching my patient along to do all this. And again, where does gas exchange take place? FRC. I want to increase my FRC. I want to have a higher level of FRC so my patient is like, yeah, okay, I'm getting that. I'm getting that. All right, here it is, devices. High frequency chest wall compression, high frequency chest wall oscillation, positive expiratory pressure, oscillating positive expiratory pressure, positive airway pressure. All this devices that, again, I've been a respiratory therapist 36 years. Some of the things that have happened here in the last 30 years, huge. When I started way back when we had the Mark 7 doing IPPB, and we would get that volume in there, but we didn't have the oscillations in there. We didn't have vests. So if we were doing chest wall compression, oscillation like that, did you not do that with your hands? Didn't we do CPT like that? And now we have devices that help us be more effective. So high frequency chest wall compression, turn that vest up and then have that vest vibrate. High frequency chest wall oscillations, again, if you're doing IPV, Menineb, all those things, that's doing that. And then positive expiratory pressure, get that pressure up there. Have them take that big deep breath in. And if you're adding external flow to that, will that add to that? Yes. Oscillating positive expiratory pressure, that's nothing new to us. We got that. Again, those devices that are out there now will do all of that for us. So, and again, my patient is breathing along, and now I have these devices that are helping them do all those things. And then positive airway pressure, because I want to increase FRC. I want to get the secretions out. So I want positive pressure back into the alveoli. And we got a slide we'll talk about or look at that talks about that. Again, these devices do what? Criteria for airway clearance device. Increase peak expiratory flow to move secretions for the oropharyngeal area. Okay, we got that. Peak expiratory greater than 60 liters a minute. Again, well documented. Expiratory flow bias needs to be 10% greater than inspiratory flow. Now look at the date on that. 1986. That was before I became a respiratory therapist by a few years. But this stuff has been around for a long time. We, again, smartest kids in the building, we have this. We have these resources. People have been talking about this for a while. And I'm very thankful for Dr. Forrest Bird to come up with this stuff to help us as respiratory therapists at the bedside to maximize all those things. He thought about this. He did this. Here's what it looks like graphically. Here's what it looks like on a waveform. High frequency chest wall, that's the vest. And again, inflatable vests used to apply high frequency pulses to the chest wall, huge. Creates inspiratory flow, breath in, breath out. Flow pulses help to mobilize secretions. That's awesome. And the cool thing about chest wall compression with a vest is this isn't just for the patient that's in the hospital. These patients go home with this. So it's not just for us at the bedside. Now, patients go home with chest wall compression devices all the time. And it's a huge plus. Again, if the patient has good alveolar clearance, they're ventilating, they're oxygenating well, the chances of them coming back into the hospital are minimized. So we want to do those things, but this is what it looks like. So we have that vest, crank it up. Get it right there where the patient's like, okay, I feel it. And again, if you're at the bedside, you place your healing hands on that patient when that chest wall is vibrating, it's significant. It is significant, but the whole time it's going back through the process of breaking it up, collecting, and moving it forward. So again, it helps move secretion safely, gets that out of the chest wall, which is what we want to have happen. Move it forward. So again, here it is, IPV Menineb. We talked about that. Forrest Bird came out with IPV and then deferent came out with the Menineb. These were designed and made for us at the bedside to maximize airway clearance. So creates positive transrespiratory pressure by injecting short, rapid inspiratory flow pulses. That's that. Many bursts of air are delivered at 100 to 300 per minute. That's why, you can really get this going. And then active exhalation enhances secretion removal. Our whole goal is to have those secretions moved out. When we first started doing IPV many, many years ago, I was thinking about when I was a student at the University of Texas Medical Branch in Galveston, we had, and probably you do too, we had a ward that was for cystic fibrosis patients. The kids would come in, and we would have to go and do it by hand, chest physiotherapy. Put them in Trendelenburg, left, right, and all like that. And I'm thinking, after this came out, I said, man, where was that? When I was in school, this would have been great. Well, now that's the standard of care. So if you have that wing on your campus, you're already using this. You know exactly what that is. So now think about this. That patient that comes in and has pneumonia, can you use it for that? Yes. That patient that comes in, exacerbation of COPD, has a bunch of secretion there. Can you use this? Yes. Is it effective? Absolutely. And again, those of us that have had the privilege to do this on patients have seen the positive results of this. It's huge. It's just a great tool for us. PAP therapy, positive airway pressure. What does that do? Flow regulating technique that increases, again, here it is, FRC, moves air behind secretions by adding external oxygen through an attached Venturi device starting at 5 liters, and it's a Venturi, so it's 45%. Those are huge tools, I think. Again, PAP devices are a big deal. Flow regulating technique that increases FRC. And again, the cool thing about this is it goes through a Venturi. So I know what my patient's FiO2 is. So while they're doing that, okay, I know what their FiO2 is. I know where I'm at increasing FRC. And again, the positive expiratory pressure, 10 to 20 centimeters of water pressure can be employed. So what does that mean? How many of you use PEEP on your mechanical ventilator? Everybody. Everybody uses PEEP. This is nothing new to us, but now it's in a handheld device. Been out for a long time, but use these things. Again, we're wanting to do what's very best for the patient that we have the privilege to take care of. All right, so here's the graphics. The definition, ventilation of alveolar structures through passages or channels that bypass the normal airway. So if you remember this in school, here it is. We have all of this. The canals of Larry, the pores of Kahn, all that stuff that we had to learn in school. It was on boards. We had to know this to take our test. So here's what it looks like. So again, pressure is going to seek the path of least resistance. So we're going to look at that. Oh, what does that look like? So here's what it looks like graphically, but we know physiologically what it's doing because we had to learn this in school. And again, if you're a nerd like I am, you visualize that. So as you're articulating your care plan, you're saying, okay, I need to get more alveoli recruited. So if you have like a family practice physician that is managing your ventilator and they say, well, give them a PEEP of 5. Well, what's that going to do? Nothing. So let's give them a PEEP of 10. Oh, a PEEP of 10, that's going to be, well, let me answer this. How did you learn to apply PEEP on a mechanical ventilator? How did you do that? I learned it. You go up on PEEP, up on PEEP, up on PEEP until cardiac output drops. Then you go back to the previous setting. So again, as you're doing this, think about that. Go up on PEEP, up on PEEP. Because again, I want to get where my patient is getting oxygenated and they're removing secretions. So here again, here's what it looks like. Here's the mucus plug. So again, we're going to see what it looks like at the alveolar level. So there's positive airway pressure through the collateral channels of ventilation. That pressure seeks the path of least resistance. So that's why we see with a mucus plug like that, we can see atelectasis. Radiographically, for your non-ventilated patient, you go in and look at the films. Oh, where's my patient's atelectasis? Well, it's in the right lower lobe. How can I affect that? So again, we've got tools, handheld tools, that will allow us to do that, to ventilate the patient, and then increase that. So mucus plug with normal breathing. Again, we're going to do a little help here. Now we're adding positive expiratory pressure. So now I'm going to go through the collateral channels to get where I have some pressure. And again, pressure seeks the path of least resistance. So now through those channels, Now I've got my equal ventilation at the alveolar level. So what is that going to do? What is that going to do? One, increase my FRC, so my oxygenation is better, but I need to get that mucus out. So how does that work? Now I'm going to get that mucus out because now the pressure is equal on both sides, and I'm going to push that plug, that mucus plug, out. So now I've achieved my goal, and we do this all the time. We see it, we do it all the time. So again, expiratory flow bias is difficult to achieve, therefore it must be combined with huff coughing. Consider the following 4 examples. Notice the effective expiratory flow bias is never achieved. So again, we need to coach our patient. So again, we're going to look at this. So again, there are some challenges to positive expiratory pressure. Again, waveforms. I love waveforms. So here it is. See, there's no waveforms because I've applied that peak pressure. There's not that oscillation. Remember the slides before where you see it was the wave? It's not because I've applied positive expiratory pressure. It's flat. So I need to do a little more. Think about where am I at? How am I helping with this? PAP therapy, 2-second eye time. Again, I'm working to that. Expiratory flow bias of 19 liters a minute. 3 seconds. Expiratory flow bias is 7, so it's not so much, but I'm increasing the volumes behind that. So I'm going to use the laws of physics to help me get those secretions out. So PAP therapy, 4 seconds. Look at how large that volume is now. But notice the bottom part of the waveform, the eye, there's no real breaking up, but I've got, okay, expiratory flow bias is only 2 liters, but I'm moving secretions because I've got that volume set behind. So again, I get that patient to cough that out. Oscillating PEP therapy uses mechanical means to interrupt expiratory flow and produce flow oscillations. That's that breaking that mucus up. Oscillations reportedly decrease the vasculoelastic properties of mucus. So again, I want it to unstick from the walls. I want it to move forward. I don't need to have it stuck. I need to move it out. That's the whole goal of doing the therapy. The whole goal of doing that therapy. And the cool thing is, I'm doing it at the bedside with a handheld device that I'm coaching my patient to use. It's not really that difficult for the patient to follow your instructions to get this through. And you've done it, you've seen it. So OPEP mechanisms, similar to a cough, expiratory flow bias. So there's a difference in EI, helps drive secretion cephalin. High frequency oscillations, the mini coughs, help thin the mucus or chop it up by creating short bursts of increased expiratory airflow. And then positive expiratory pressure, I love this, increases FRC and also helps air get behind the secretions from the collateral ventilation channels. Just as we looked at that waveform, and just as we looked at the screen that showed the alveoli and going through, the pressure going through, the volume going through, the collateral channels ventilation, it's happening. Now, again, years ago when you took your boards, you had to know that stuff. Now, every day, we're just out there, okay, let me do this neb, let me do this, let me do this. You may not be visualizing that, but I'm going to ask you right now, as you move forward, take a minute with each patient that you have the privilege to serve and think about what is going on dynamically with that patient. We're not just a bunch of neb jockeys. We're thinking about what's best for my patient. So again, take a minute when you're doing this and visualize in your head, where am I at with this patient? What do I need to do? And encourage that patient, coach them up. Oh, Mr. Miss Smith, take a slower, deep breath. Yeah, pause for a minute and then blast it out. All right, here's critical OPEP components. Deeper than normal breath, but not all the way to TLC. I don't need to have them take 3,000 cc's. I don't need that. But larger than normal breath. So if their normal breath is 150 cc's, I need to get a little bit better than that. 500 to 700 cc's probably will help them along. Allows achievement to increase peak expiratory flow. So the next one, do that breath hold. Now I get that distribution of ventilation through the collateral channels of ventilation, and then alters time constraints, allows flow to move behind the obstruction through those channels, and then active exhalation to produce expiratory flow bias and flow oscillations. The whole goal of this, the topic was expiratory flow bias. I need that. If I don't have that, I'm not going to be a helper. So expiratory flow bias, so take that big deep breath in and then blast it out. And then the flow oscillations break that mucus out, help it move forward, cephalid. All right, here's the tale of two patients. And we probably do this all the time. So Ms. Smith and Mr. Jones, two patients who are performing OPEP therapy. The resistance is set on the lowest setting because we're teaching our patients, we're coaching them up. I want them to do this. For the purposes of what we're talking about this morning, both are exhaling at 1.5 liters of air and have a peak flow of 60. Okay, pretty generic. Both patients have been instructed by you and me, breathe in slowly to a volume slightly larger than normal, hold their breath for a couple of seconds, and then perform a steady exhalation for 3 to 4 seconds. So we're coaching them up. We're doing that instruction. We're coaching them. We're teaching them. So Miss Smith wants to get the therapy over with. She's got a hair appointment later and she's ready to go. Mr. Jones is more cooperative. He's inspiring at 1.5 liters over 3 seconds. He's got yard work to do today, so he's taking his time doing this. Do the math. Miss Smith, she's just flat. She got an IE ratio of 1 to 1. There's no big deal. So again, it's like, there's no flow difference. The EI difference is 0. Mr. Jones listened to what you were saying, follows through with that. So now he has a difference of what? 2. So he's going to get a little more expiratory flow to move secretion, cephalid, and then have him cough. So the OPEP theory will be more effective for Mr. Jones since he has a greater expiratory flow bias. So again, as you're coaching your patients up, they have a whole host of things going on in their lives. Some will listen, some won't. But you're going to have to hold their hand and say, I'm here to help. I want you to do well. I know you don't want to be in the building anymore. I want you to go home safely. Listen to what I'm saying and coach them up. And it may take several times, several therapies before the patient finally understands what you want. Just don't say, well, here's your OPEP device and I'll see you tomorrow or see you later. Don't do that. Take a little bit of time and coach your patient up. Get them to understand what you're doing and why it should take. So the takeaway there is in order to maximize expiratory flow bias, patients should take in the slowest possible breath. Does that make sense? It's not anything new to us. We've got that, but we need to have them say, okay, how do I do this? Here's one of the things that I want to focus on and talk a little bit right here. We're going to take a pause on the therapy. How many people that you have, patients that you have, go home with this therapy? Do you send them home with this therapy? So again, your instruction at the bedside is going to help them do it at home. How many of you have patients that you see in the hospital? You take care of them. They're there for 4 days, 5 days. You instruct them. And 2 weeks later, they're back in the ER. You ever had that? They're readmitted. Again, that's a big issue for hospitals. A huge big issue to have that patient show back up. There are penalties for that patient that shows back up within 30 days. So again, think about what you're doing, coach your patient, encourage them to take these devices home and then use them at home. I love my patients as much as you do, but I don't want to see them back in the building for at least 31 days. Whether they come in back to the hospital that I'm at or they're admitted to the hospital across town, within 30 days, you're penalized. You're penalized. Now, for a hospital of 250 beds, that could represent several hundreds of thousands of dollars. For a larger hospital, 900 beds, 1,000 beds, that could represent millions of dollars of penalties that you're paying when that patient shows back up. So again, when you're teaching your patients, look over the horizon and say, I need to make sure my patient takes this and does this at home. So again, in order to maximize expiratory flow bias, patients should take the slowest inspiration possible. Breathe in, take that big, deep breath in. Now, here it is. This is what we were just talking about. CMS paid for performance, hospital readmission program, reduction program. So out of that, CMS looks at these admitted things: heart attack, heart failure, coronary bypass, hip knee replacement, pneumonia, COPD. Where we focused in, the last one, COPD. So again, that's our focus right there. Now we're really going to drill into it. Hospital readmission reduction program. The financial penalty to the hospital is going to be up to 3% reduction in Medicare payments. If your campus is like the ones that I've worked at, 70 to 80% of the patients that you treat are Medicare, Medicaid patients. The other are insurance companies. Now, insurance companies are looking at this as well. Now, hospital reduction program, we can look at and say, well, what does that mean? Financial penalty. So 3%, think about the amount of patients that you have. 3% of what you're getting back in payments can be a penalty. You're not going to get that money. You aren't going to get that money. For us as the clinicians at the bedside, that may not be such a big deal. Okay, well, I'm not really sure what the finances are. I don't know that. But if there are directors out there that are listening to this, you understand, you get this. You understand what that means, especially if you say, well, I need to get new ventilators. And so you ask, you get a quote and you say, well, they're $30,000 a piece and you need 10 new ventilators. That's $300,000. So you're writing your capital budget for next year. Well, I need $30,000. So you write it out. So here's your capital budget. Now you go to, the COO or whoever you visit with in the carpeted side of the building, and most of it will be like with the CFO. You say, well, I need 10 new ventilators. Well, how much do they cost, Steve? Well, they're $30,000 a piece. I need 10 of them. Well, Steve, that's $300,000. Well, yeah, I know. Isn't that great? Well, yeah, but I just spent $1.5 million on an MRI for radiology. I don't have that money this year. What? Yeah, but I got old ventilators. They're 20 years old. I need to replace them. Here's an opportunity for you as a director in pulmonary care. Take a look at what your readmission is. Go to case management. I can assure you they'll know right away what percentage of those patients that you treat that have COPD are readmitted. If you say and do your homework, well, if I can mitigate those readmissions, would that be a plus? Yes. Start to do your homework, track that, and say, well, if I minimize this, then the next year you can say, well, I reduced my readmissions for COPD patients, and then the national average is 22. So you reduced it from 22 down to 18%. Think what that is financially and do the numerics, and you will find now you're going to fund your own ventilators. And again, it's a huge deal. It's a huge thing. So start to think about that. So here's the admitting DRG. The payments are capitated. So DRG, Medicare, Medicaid, they're capitated. No matter what happens, they're capitated. Now think about what your costs are. So if you have, without complications, what does it cost to have you have a patient in your hospital per day? Not what you get reimbursed for, what's it cost you? Think globally. So you're paying for respiratory therapy through this DRG, OT, PT, dietary, nursing services, pharmacology, radiology, and the physician there that's at the bedside. What is your cost per day for an ICU bed? What is your cost per day for a floor bed, ward bed? There's a difference in there. It's more an ICU because again, now you have like for nursing services in ICU, it's 2 patients per nurse, whereas on a floor it could be 5 patients per nurse. And the same for us as respiratory therapists, we may have 4 or 5 patients that we're taking care of on mechanical ventilation or in the ICU, whereas on a ward bed, you may have a lot more, more than that. You're all over the building. You're on 3 or 4 floors. You may be taking care of 15 or 20 patients during the day doing neb treatments like that. But think about the cost is. What does it cost the hospital to pay for that patient to be in that hospital? So again, think about that. How can I minimize that? Think about that. What do I need to do? Keep them out of ICU, move them, and help. So again, in review, OPEP therapy, peak expiratory flow, move secretions, cephalid, oscillations, reduce viscosity of mucus, positive Expiratory pressure helps move air behind the secretion. We looked at all those slides. We understand that. We get this. We're the smartest kids in the building, and people just don't know how smart we are. We had to do all about this. Oh, what about resistance? Again, there's the resistance. I want to get that. So the effects of increasing OPEP resistance, there are on all of our OPEP devices, no matter who the manufacturer is, there's a little slide on there or dial or something like that, that I can increase the resistance to that. So I'm adding that back pressure. So it increases mean airway pressure, which may help treating atelectasis. Hello. So we have a whole host of things we can do. So here I'm treating atelectasis. Increases FRC, which promotes mucus clearance by stenting the airways open, allowing airflow to move behind the secretions through the collateral channels. That's a plus. Those are all good things. The negative effects, remember we talked about the IE ratio difference? Not so much. So again, but I want that. I want to have that where I'm getting that volume at the FRC at the alveolar level, opening that alveoli up, and then moving secretions, cephalid, cough, spit, and don't spit on the therapist. Therapist good. Also, in an OPEP device, frequency is directed to proportional flow. That makes sense. The higher the flow, the greater the frequency. So again, it's the patient takes that breath in and they blow out slowly. Not so much. Take that big breath in, breaks it up. You've seen it, you've done it. Therefore, patient low tidal volumes may be well below the ideal target, where we have patients with high volumes well above. More work's needed to find the ideal range. I put that in there, more work's needed. Again, it is specific to the patient. Each one of our patients is unique. Now, we may have a whole host of patients, but I want you to think about that. Mr. Smith is different than Ms. Jones. Ms. Jones is different than Ms. Jackson. Ms. Jackson is different than Mr. Smith down the hallway. Each one is different. So again, as you're placing your healing hands on that patient and you're working up your care plan and you're articulating that, it is based on that patient's specifically. So as you write your care plan out, it's based on that patient. So whatever's needed to treat that patient, not in a global sense. Remember we talked about that family practice physician that's doing mechanical ventilation says, oh yeah, let's put them on a PEEP of 5. Well, okay, that's a generic. That's like, no, we don't do that. We don't do that. We design that. We do the peak flows. We do all of that specific to what is going on dynamically with that patient. So again, OPEP device, a handheld device, specific to that patient. Think about what you're doing. So again, here's the bottom line, PEP versus OPEP. Secretion movement with a PEP device works through more collateral ventilation channels and less through modulation. We got that. I'm talking about that. Secretions movement with the OPEP device works more through modulation of expiratory flow bias and less through collateral channels ventilation. We get it. I got it. I'm ready to go. Now, how about this one? Combining those two. How many of you do that? Right now, how many of you combine PAP therapy with OPEP devices? So here I have my OPEP device. Then I have a PAP device that I can tie in to my OPEP device. Remember, we talked about that a few slides ago. Now I got a Venturi device. Is that a PAP device? I increase the liter flow from 5 to 7 to 8 liters maybe, and my FiO2 stays the same that I'm delivering because it's going through Venturi. I'm PAPing the patient. I'm giving them some PEEP, positive airway pressure. Now I'm modulating, breaking that up. Can that prove to be beneficial? Yes. And we do that. We do that every single day with the patients that we're moving through the continuum of care. We do that. Start them out in the ED. Remember I talked about cystic fibrosis? When I was in school as a student, the first time I had patients over in the cystic fibrosis ward, most of the time you show up, I would have like 15 or 20 patients I had to take care of. Well, when I got assigned over cystic, I had 3. I'm thinking, wow, wait a minute. I went from 15 to 3. This is the greatest day ever. Well, I didn't think about, again, as a student, you didn't think about, oh, I'm doing chest physiotherapy. And again, you're having to do that. So you put them in Trendelenburg, you're doing it left to right, and all like this. And like at the end of the first round, after three patients, my arms were about to fall off doing CPT. Now we got vets, we don't do that. But I'm like, oh my gosh. And I just remember this one boy, I think he was probably, I don't know, maybe 10, maybe 12 years old. And it stuck in my mind. I put him in there, put him in Trendelenburg, and he says, I want to call my mom. You're not doing this right. I'm thinking, oh yeah, please call your mom. Tell her I'm not doing it right. We go through that. So again, with cystic, we got it. The last line there, we need to have it individualized to the patient. Now, again, the normal care right now, everybody has that, and we send our patients home with that out of those cystic wards. We've been doing this for a number of years. Uncomplicated pneumonia, CPT is not recommended. Yeah, hello. How many times says the physician right do CPT? So again, you got this little grandma lady. She's 85 years old. You go in there and the physician wrote, okay, CPT, QID. So you get in there, okay, Ms. Jones, here's what we're going to do. I need to do chest physiotherapy. So we explain it to her. She's like, oh, okay, go ahead. So you raise the bed up and you put her in Trendelenburg. And as soon as her head drops below 90, she's like, stop, 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 stop. So you stop. And she says, don't do that. So then you ask, so what I guess I hear you saying is you're refusing therapy? Yes, I refuse her. So you put her back into a normal sitting position, and then you go in and you write patient refused therapy. Good. I didn't have to do CPT on her. So now here's some other opportunities that we have to do this. So high frequency chest wall compression, the vest, PEP therapy, OPEP, effective alternatives to CPT. And I didn't come up with this. You didn't come up with this. The American College of Chest Physicians, hello, they came up with this. COPD is not recommended for those. Why? How am I going to put them down in Trendelenburg? As soon as you drop their head, what happens? Or even if you take them out of semi-fowlers or high fowlers, some of them are posturing like that. You drop them down, oh man, I can't breathe, I can't breathe. Okay, okay, I understand, sir. I got it. Or ma'am, here, let me help you. Here's this. So again, we understand it. We see it every day at the bedside. Every day, every day. So in summary, high frequency oscillations, mini coughs, help decrease the vasculoelastic properties of mucus. Expiratory flow is the key component to effective secretion movement. And then here it is. I need that bias. Expiratory, inspiratory flow bias is needed to move secretions toward the upper airway cephalid to have the patient take in that big deep breath in, cough, and spit. We've got that. We understand that. As you're doing this every single day, think about these things. Now that you're at the bedside, you're placing your healing hands on that patient. Just take a second with each patient that I'm like, okay, what am I doing? What's my goal here? What do I want to have happen? We talked about pay for performance, hospital readmissions. I love my patients as much as you do, but I don't want to see them back in my building for at least 31 days. I don't need to see them go across town either because I get penalized. So you, smartest kid in the building, think about this. So I coach them up and I want them to go home with this therapy. So Mr. Smith, I want you to show me how to do this and have your patient show you. And then you can write in your care plan or you articulate in your notes, and you have to do it anyway. I taught the patient how to do this. They repeated this, and again, sign it, RRT, and away you go. So do these things every single day, and then we'll have a better outcome for our patient. Think about this. What you do every single day is great. It's fantastic. And I hope you think about this. One day, a loved one of yours is going to have their head in the bed. And you're hoping that wherever they are, that whoever's taking care of them takes care of them the way you would take care of them. And then ultimately, one day, your head is going to be in the bed. And you're hoping that whoever's taking care of you has the thought process, I'm going to do the very best I can for this patient because one day it's going to be me. So again, we've got that. We do that. We do that every single day. So while increasing OPEP resistance with an inline PAP device may be helping treat atelectasis, yay. Increase flow bias will be maximized when the respiratory care practitioner sets the resistance on the lowest setting and instructs the patient to take the slowest breath possible. We're teaching the patient, teach them how to use this stuff. I can't reinforce that or state that enough. Again, one day your head's going to be in the bed, or your wife, your husband, your kids, your parents. You want somebody who's as mindful of the care that's being delivered as you are with the patients you have the privilege to take care of. All right, here we are. Tell me if this isn't a true statement. Respiratory therapists are the Batman and Batgirl of healthcare. We get the signal, we show up with all of our gadgets, we save the day, then we disappear and no one knows their name. Is that not true? How many times have you had a nurse come out of a ward bed or an ICU and say, "Hey, respiratory"? Now you may have a familiar relationship. They may know your name, Steve, Bob, Jim, Jill, come on, I need your help. But sometimes may not. So you go in there with your gadgets, your pulse oximeter, and you say, "Oh, my patient's SAT is 85. Oops, that's not a good thing." So you find out why. Well, I'm going to fix their SAT. So if they have an order for 2 liters a minute, I'm going to turn their oxygen flow up to 5 liters a minute because I'm going to fix that SAT. If they're at 85, hypoxemia kills, I'm taking them up to 90. So I got to turn that flow up to 5 liters a minute, then find out, well, why they're at 85 when they're on a 2 liter. What's going on? So now I'm going to ask my nurse, well, what's going on? Or if they call and say, well, the patient's wheezing really bad, hey, respiratory, come in. I'm going to give them a neb treatment right there. And I'm going to find out what's going on dynamically with the patient, fix them, and then go on down the hall to the next one. And then the nurse is like, I don't know who those respiratory therapists are, but man, they're the bomb. And we are the bomb. We are the smartest kids in the building. And go ahead and admit it. You are the smartest kid in the building. I'm done. Anybody got any comments? Anything? I'm ready. So, Keith, if you open up the question, I'll do my best to answer questions.